she's one of the key opinion leaders in the field of clinical-oncology in Israel. She had a fellowship, a clinical fellowship in clinical studies between 1996 and 2000 at the North Cancer Center in Los Angeles, USA. She has a lot of clinical experience and she's doing also research. And since 2010, she's head of the clinical oncology service at the Thoracic Medical Center in Tel Aviv. It's a great pleasure for you.
Thank you very much. We're going to talk about anthracycline with reduced toxicity. Why is it so important? You know, with all the new drugs we are hearing about, it seems like chemotherapy is the old story, but actually I think chemotherapy is still the backbone of the treatment in many diseases. If we're talking about breast and ovarian, anthracycline, taxanes, platinum, and trastuzumab, Herceptin are still very important drugs, and we cannot move to biologicals or others yet. If we look at doxorubicin, which is one of the anthracyclines, one of the main used anthracyclines, we have information from 79 as well as from 2003 showing how much cardiac damage we have from the drugs. So if we look here, we know that the damage is related to the cumulative dosage of the doxorubicin, and in 1979 we're still relying on that study. Van Hoff showed about 3% cardiotoxicity on more than 400 milligram per meter square cumulative dose of doxorubicin, and it increases when it goes up. Swain in 2003 showed a bit higher rates of cardiotoxicity, and that's what sets the behavior of not giving more than 450 to 500 milligrams per meter square of cumulative doses of doxorubicin. That's how we behave today. When you're talking about breast cancer, you know that we give 4 doses of 60 milligram per meter square in the adjuvant setting of breast cancer because we do not want to cross the 300. If we're talking about metastatic disease, we do not cross the 450 milligram per meter square cumulative dose because of those informations. When we look at old people compared to young people, we see that the curve bends earlier. If we were talking about 450 milligram per meter square of cumulative dose, which is the limit of what we give in young people, when we look at older people above 65, the curve goes higher earlier than that. But that's our limit. We know that combination with anthracyclines cause even more cardiotoxicity. If we combine doxorubicin and paclitaxel, we can get as high as 25% cardiotoxicity. And if we combine doxorubicin and Herceptin, we get as high as 27% cardiotoxicity. And that's why we do not do those combinations in the regular treatment. We give them consequential or in the other way, but not together. We also underdiagnose cardiotoxicities, as other people talked about it before, because we do see the early toxicity, which is immediately or after a year, but we don't really follow the many years later toxicity. If a patient comes to her doctor 20 years or 30 years after she received adjuvant chemotherapy for breast cancer, they don't always connect between the cardiotoxicity and the earlier administration of anthracyclines. So we do miss a lot of the cardiotoxicity related to the chemotherapy. We already saw this slide as 1% of the cardiotoxicity is related to doxorubicin administration, and we know that about 50% of those population will die of cardiac disease, despite the fact that they got cured from breast cancer. What are the risk factors for developing cardiotoxicity? We are talking about the cumulative dose. We saw that we do not cross the 450, 500. Underlying cardiac disease were also discussed this morning, like hypertension, diabetes, cardiac disease. Radiation, mainly to the left side, but maybe to both sides, do cause more cardiotoxicity. And very young and very old people develop more cardiotoxicity than other populations. What can we think about how to reduce the toxicity? One thing is to reduce the peak plasma concentration. And we know years ago we used to give sometimes 20 milligram per meter square every week instead of 60 or 75 milligrams every 3 weeks, because we saw that the small doses administration, like continuous administration or over 96 hours of smaller doses, creates less cardiotoxicity. So reducing the peak plasma concentration, not giving it in high doses, might reduce cardiotoxicity, and the affinity to cardiac cells compared to tumor tissues could differentiate cardiotoxicity. If you look at Doxil or Calyx or pegylated liposomal doxorubicin, which is a drug that was invented like 15 years ago, 20 years ago, few Israelis like Alberto Gabizon were involved in developing this drug. It's the old drug, the old anthracyclines, coated in liposome and coated in pegylation on the outside, which makes it evasive to the immune system. So the drug circulates in the blood to a half-life of about 45-50 hours, which makes it there for like 10 days in a reasonable amount. Because of the fenestration in the neoangiogenesis of the tumor tissue, it can evade the tumor tissue and stay here for a long time and release the drug in a slow way because of the liposome in a slow release way. So we have a lower dose for a continuous amount of time. You can also see on biopsies that if we look at the damage to the mitochondria of the cardiac cells, we see that doxorubicin causes much higher toxicity to the cardiac cells than the PLD or Doxil or Calyx, meaning that there is less affinity to the cardiac cells by the new drug compared to the old free doxorubicin. We can also look at the amount of doxil circulating in the blood. We see PLD do not release too much conventional free doxorubicin compared to doxorubicin itself that first disappears fast from the blood, but also releases large amount of free doxorubicin to the blood when the PLD itself releases about 2%. So as of all, we have a drug which is less cardiotoxic, mainly, not only, but mainly because of the lower peak plasma concentration and different affinity to the cardiac cells. In general, it's a very different drug than the doxorubicin, though it's as effective as, I'll show you later, but the toxicity profile is very different because of this behavior. It causes much less alopecia or loss hair, less nausea and vomiting, and less myelosuppression than the free doxorubicin, which is the father drug. It causes less cardiac toxicity, and it causes more hand and foot syndrome, and lots of skin toxicity and mucositis. Like about 15 years ago, we tried to see how much of the cumulative amount of the drug we can give to the population. We collected about 237 patients that were put on 8 studies with a PLD. Out of them, 42 received more than 500 milligram per meter square cumulative dose, which was the accepted dose, and we wanted to see what happened to them. So those patients received between 500 to 1500 milligram per meter square of PLD. 6 of them went through biopsies, and we wanted to see what's the heart reaction to the drug. We had ovarian cancer patients, breast cancer patients, and others in those 42 patients. The median dose of anthracyclines was 660 milligram per meter squared, though all of them received between 500 and 1500. When we looked at the reduction in ejection fraction, which is how we measure cardiac toxicity, I just wanted to say on the side that it's not the best measure we have, reduction in ejection fraction, but that's the only way we manage to follow cardiac toxicity. We know that troponin or other blood materials do not help us know whether the drug did cause cardiac damage or not. Ejection fraction reduction of somewhere between 10 to 20% or below the threshold does give us information about cardiotoxicity, but it's not the best measure. We don't have a better measure than that. That's why we're using that. In this study, in those 42 patients that received more than 500 milligram per meter squared, we saw that there was no correlation between the change in ejection fraction and the cumulative dose of the anthracycline. So we concluded that PLD can be given in a safe way in doses above 500 milligram per meter square. you can stretch it to more than 2 years. I just wanted to say about the original doxorubicin, if you're limited to 450 milligram per meter square and you give 60 milligrams per time every 3 weeks, we are limited to about 6 to 8 months of administration. If you're using PLD, we can give it to more than 2 years because the amounts are smaller and it doesn't cause cardiotoxicity, so are not limited by time. In anthracycline, when the drug is effective, we need to stop when we get to the 500. With PLD, we do not need to stop because it continues to be effective and it doesn't harm the heart. And we can also use it in patients that was previously treated by anthracyclines, and we can continue with the PLD without damaging the heart. Let's look at some studies like breast and ovarian studies. One of the first phase 3 studies were O'Brien studied, which compared the efficacy of the original doxorubicin to the new PLD. So we gave 50 milligram per meter square of PLD compared to conventional dosage of doxorubicin. You can see that progression-free survival was similar, overall survival was similar in response to it. So similarly, it's the same drug relating to the cancer, but it does cause reduced cardiotoxicity. Progression-free survival as well as overall survival were similar in both studies. And we see this curve again. We can see that above 450 milligram per meter square of the conventional doxorubicin, we're starting to have too much cardiotoxicity. When we look at the PLD, we see that there is some cardiotoxicity, about 10%, and it continues. It does not relate to the cumulative dose of the drug. So we do give PLD as long as we want. We do measure ejection fraction every 2 or 3 months, and we do follow cardiac toxicity, but we don't see too much of it. We do see an even greater benefit in subparts of this population. Patients older than 65 are more prone to develop cardiotoxicity, and the difference between PLD and conventional doxorubicin was p-value of 0.001 in favor of the PLD. The same for cardiac risk factors. Patients with cardiac disease, with hypertension, etc., had a hazard ratio of 2.7 in favor of the PLD. And when we talked about prior adjuvant anthracyclines and re-challenge with anthracycline, the hazard ratio was bigger than 7. So lots of population can enjoy the use of PLD compared to the conventional doxorubicin, but those high-risk population gain even more from the use of this drug if it's effective. So we can conclude and say that in breast cancer, it has a comparable efficacy, it has lower cardiotoxicity, and it has a very different toxicity profile. What about administering the drug after the previous use of anthracycline, meaning re-challenge of anthracycline to population that had to stop because the drug was still effective, but the amount was too big and potentially created a cardiac toxicity. So we gave pegylated liposomal doxorubicin in 50 milligram per meter square to patients that already received anthracycline before that, and we couldn't continue because the dose was too large. Patients received 1, 2, or 3 regimens of chemotherapy before that. And we can see that the efficacy was pretty good, 24% response rate. Progression-free survival was 3.6 and 12.3. And the main thing was, despite the continuous use of very high dosage of anthracyclines, they did not develop cardiac toxicity. The next issue in breast cancer was the combination with Herceptin or anti-HER2 therapy. I showed you before that the cardiotoxicity of combination of anthracycline and Herceptin can get as high as 27%, and it's too much to be administered. We have one study that evaluated pegylated liposomal doxorubicin together with trastuzumab. It's CHIA study. If we look at the combination with trastuzumab by itself causes about 2 to 4 class 3 to 4 cardiotoxicity. If we combine it with other anthracycline, it can get as high as 27, but 60% class 3 and 4. If you combine it with paclitaxel, we don't have so much toxicity. So the combination of trastuzumab and Taxol is acceptable. The combination of trastuzumab with anthracycline is not acceptable. We give anthracycline and later we give Taxol with trastuzumab. Why is it? I know that you heard the lecture in the morning. Sorry I missed it. I was in a meeting and I couldn't come, so she might have explained it much better than me. But the HER2 system helps to repair damage in cardiac cells. If we give anthracycline that causes damage to the heart cells, and then we give together Herceptin, we block the way the body repairs the cardiac cells. So that's some of the explanation why we cannot give anthracycline together with Herceptin or with anti-HER2 therapy. In this study, Chia gave pegylated liposomal doxorubicin together with trastuzumab, and actually we don't really see, we see a good response, and we don't see a big difference in ejection fraction, meaning there is not too much damage to the heart by the combination of PLD and Herceptin. And that's his conclusion: cardiotoxicity is much lower. If we move to ovarian cancer, where the drug is also very important, we started using PLD amongst other treatments to ovarian cancer in the late 90s, 2000. At the beginning, it was compared to one of the acceptable drugs at that time, the topotecan was compared to the PLD. When we see similar responses, maybe a bit better to the PLD. No really reports about any cardiotoxicity in those groups. This is the comparison between the PLD and topotecan. We don't see cardiotoxicity mentioned. We do have hand and foot syndrome. All the stomatitis and skin toxicities are much more in PLD, but we don't have cardiotoxicity. We don't have actually a cardiac limiting toxicity that will stop us treating patients that do respond to the anthracyclines in this formulation. This study concluded that it has a significant survival advantage. It has a 30% reduction in this population, and actually it did not cause any cardiotoxicity. It was compared to paclitaxel and showed also similar activity. So it's a very important drug today in ovarian cancer. We also combined it with carboplatin, which increased the response rate from about 30% of the single agent response to about 70%. And we use it in difficult cases when we need a fast response to the combination. We use PLD together with carboplatin. We don't see too much cardiotoxicity in our population. We see other side effects, but we don't see cardiotoxicity. We don't see alopecia. We don't see nausea and vomiting. And myelosuppression is much less than the other drugs. And that's because of the special formulation of this drug, which is actually an old drug put in a new formulation. Where would we use the PLD? We use it in ovarian cancer as a single agent, as in combination, because it's a very important part of the armamentary in ovarian cancer. We use it also in breast cancer, either as rechallenge. Patients that receive anthracycline in the adjuvant setting do receive it later in the metastatic setting, what we cannot do with the conventional anthracyclines. It can be used together with trastuzumab, which is very important to us in breast cancer. Patient with cardiovascular disease, either old patient, cardiovascular high risk, or any reason why not to use anthracycline, can be treated by PLD with similar efficacy. Patient old or very young would benefit from that. And patient that the risk for the toxicities, for other toxicities, are too much. We know that it causes less myelosuppression, it causes less nausea and vomiting, and when we do not want to cause alopecia, which most of the patients do not like it, we can use PLD in similar efficacy with less toxicity with the PLD. And I send you straight to lunch, but I'll be happy to answer questions.
Open for one or two questions. So I guess everything is clear, so I give my microphone to my coach.
Yeah.
Actually, my question goes to Dr. Tamar about the you mentioned actually there is